In this session, we learn about the inguinal canal in a nutshell. Actually, in detail, it will be taught in your clinical anatomy classes over hernia. But in this session, we will just have a overlook of this region. Inguinal canal. Before going into detail of inguinal canal, we must know one thing, that is, what is inguinal ligament. What is inguinal ligament? Another name of this ligament is Popper's ligament. What is that? This is the thickened lower border of the aponeurosis of external oblique, which is folded backward, presenting a grooved upper surface. What does it mean? Suppose this sheet of paper is the external oblique aponeurosis, and this one where I have hold it, this is the inferior the lower margin of the external oblique aponeurosis. According to the definition, the lower part is folded backward like this, and it is becoming thickened like this. This one, it has grooved upper surface. You can see here, this has grooved upper surface, and this is known as inguinal ligament. The length of inguinal ligament is about 12 to 14 centimeter in case of adult. Again, I repeat, what is inguinal ligament? This is the thickened lower border of the aponeurosis of external oblique muscle, which is folded backward, presenting a grooved upper surface. Attachment. It is attached laterally to the anterior superior iliac spine and medially to the pubic tubercle. So, if this be the inguinal ligament, the attachment is like this: laterally from the anterior superior iliac spine, medially to the pubic tubercle. And the course of this is not like this. The course of this inguinal ligament will be a little convexity have downward. On the lateral side, it goes downward, forward and medially, and the medial side is almost horizontal. So, this is the direction of the inguinal ligament. So, you can see here it has got a convexity downward. Why this is convex downward? This is due to the pull of the fascia lata, because the fascia lata, that is the deep fascia of the thigh, this is attached at the lower margin of this inguinal ligament. So, other than this, what are the other structures which are attached to the inguinal ligament? Over the lower border or the lower surface, the inferior surface, the inguinal ligament, it gives attachment to the fascia lata here. The upper grooved surface, this is the upper grooved surface where there is presence of two muscles. The muscles are the internal oblique and the transversus abdominis. This is like this. The red one, this is the internal oblique. The internal oblique is arising from the lateral 2/3 origin of internal oblique, and if we remove it, we can see the blue one, which is arising from the lateral 1/3, which is posterior to the internal oblique. This is transversus abdominis. So, the upper groove surface gives origin to the internal oblique muscle from lateral 2/3, and posterior to that from the lateral 1/3 gives origin to the transversus abdominis muscle. What about the posterior margin attachment? If it is folded like this, and this is the posterior margin, so it is present here. Along the posterior margin, there is attachment of opposite to the femoral sheath. Suppose this is the position of the femoral sheath like this. So, opposite to the femoral sheath, the fascia transversalis enters the thigh as the anterior wall of the femoral sheath, whereas the fascia iliaca forms the posterior wall of the femoral sheath. By this time, all of you know this one. You have gone through about the femoral sheath in your inferior extremity class. And lateral to the femoral sheath, that means in this position, the fascia transversalis and the fascia iliaca, they are attached to this margin, and medial to that the same thing occurs. Only along this space opposite to the femoral sheath, the fascia transversalis and the fascia iliaca, they are not attached with each other, and the fascia transversalis, it forms the anterior wall of the femoral sheath, and the fascia iliaca is forming the posterior wall of the femoral sheath. So this is about the attachment. Next thing you must know, that is the expansions of this inguinal ligament. This is the inguinal ligament. There are three expansions. What are those? Number one, lacunar ligament or Gimbarnut ligament. What is that? This is a triangular shaped ligament from the medial side, like this. This is a triangular shaped ligament on the medial side. So it has got one base, one apex. The apex is attached to the pubic tubercle and the base is free, which is forming the medial boundary of the femoral ring. Anteriorly, it is attached to the inguinal ligament, and posteriorly, this is attached to the pecten pubis. Here there is pecten pubis, and posteriorly, this is attached to the pecten pubis on its medial side. So this is the lacunar ligament, which is triangular in shape and extends backward from the medial side of the inguinal ligament. Next one, this is the deflected part of the inguinal ligament. The deflected part of the inguinal ligament will be attached like, just a minute, this is the symphysis pubis, this is the opposite sided, and this is the position of the linea alba here. This is the position of the linea alba here, and the deflected part of the inguinal ligament will be like this. The deflected part of the inguinal ligament will be like this. So this is the deflected part of inguinal ligament. So some few fibers from the pubic tubercle, they will go upward to get attached to the linea alba. And the third expansion of this inguinal ligament is the pectineal ligament of Cooper. This will be present here. This is the pectineal ligament of Cooper. This is the pectineal ligament of Cooper. This one. So it from the base of the lacunar ligament, a fibrous band extends laterally and is attached to the rest of the pecten pubis. So this one. So these are the three expansions, is very important for you. What are those? Number one, lacunar ligament. Number two, the reflected part of the inguinal ligament, and number three, this is the pectineal ligament of Cooper. Now we will enter to our topic proper. This is the inguinal canal. So first, what is inguinal canal? It is a musculo-aponeurotic tunnel about 4 cm in length, extends from the deep inguinal ring to the superficial inguinal ring, and it is above and parallel with the medial half of inguinal ligament. So suppose this is this is not. Suppose this is the Suppose this is the inguinal canal. This will be present like this on the medial half of the inguinal ligament. Parallel with it, it is a musculo-aponeurotic. Why this is musculo-aponeurotic? After the formation of inguinal canal, I will discuss. Then you will come to know why this is known as musculo-aponeurotic tunnel. And this is about 4 cm length and extends from the deep inguinal ring to the superficial inguinal ring. So this opening, if this is the tunnel, then this is the opening. This is the deep inguinal ring through which the canal is being started, and this is the opening from where it is coming out. This is the superficial inguinal ring. Now the contents of the inguinal canal. If we consider the contents of inguinal canal, then we can divide it into two parts. What are those? Number one, full content, and number two, partial content. Number one, full content, and number two, partial content. Again, full content is different in case of male and in case of female. In case of male, the entire or the full content is the spermatic cord, and in case of female, it is the round ligament of uterus. And the partial content for both male and female, it is ilioinguinal nerve. Why these are full content and why this is the partial content? Because in case of male, the spermatic cord, and in case of female, the round ligament of the uterus, they will enter into the inguinal canal through the deep inguinal ring and will come out from it to the superficial inguinal ring. But ilioinguinal nerve, this is known as the partial content. Why? Because this is the nerve which enters into the canal by piercing the internal oblique muscle about 2.5 centimeter below and medial to the anterior superior iliac spine. That means it will enter through the roof, opor theke nambe. সেই জন্য এটাকে বলা হয় partial content, as because this ilioinguinal nerve will not enter into the canal through the deep inguinal ring, but it will enter after piercing the roof, and it will come out through the superficial inguinal ring. That's why this is known as partial content. Next heading, this is the boundary of this canal. So the canal being like this, this is the canal. So it has got one inlet, one outlet, one anterior wall, one posterior wall, one floor and one roof. As because this inguinal canal is above and parallel with the medial half of the inguinal ligament, so you can imagine that the floor is formed by the grooved upper surface of the inguinal ligament, and most medially lacunar ligament form some part of the floor. If this is the inguinal ligament like this, this is the inguinal ligament is like this. আমি anterior wall টা একটু ছোট করে দিচ্ছি তোমাদের দেখতে সুবিধা হবে, and this is the posterior wall. So this is the position where the inguinal canal is there. So this part, this is forming the floor, and medial most side lacunar ligament is forming the medial most part of the floor. What about the roof? Just when we were learning about the inguinal ligament, the attachment of the muscles and other structures to the inguinal ligament, we have come across that the internal oblique muscle and the transversus abdominis, the red and the blue one, they are attached to the upper groove surface of the inguinal ligament, and these fibers are like this, right? So the arched fibers of the internal oblique and the transversus abdominis muscle, they are forming the roof of the inguinal canal. So the floor is formed by the grooved upper surface of the inguinal ligament. এদিক থেকে দেখো, the floor is formed by the grooved upper surface of the inguinal ligament, and medial most part it is formed by the lacunar ligament, and the roof is formed by the arched fibers of the internal oblique and transversus abdominis. Now come to the posterior wall. The inguinal ligament is like this. Suppose this is the posterior wall, this is the posterior part, this is the grooved, this is the posterior part, this is the anterior part of this external oblique aponeurosis. We have just learned just posterior to this there is attachment of the fascia transversalis like this. The fascia transversalis is present here like this. So the posterior wall is entirely formed by the fascia transversalis, which separates this canal from the extraperitoneal tissue and the parietal layer of the peritoneum, and it is partially formed by, on the medial side, it is partially formed by the conjoint tendon in front of fascia transversalis, and in front of that there is presence of reflected part of the inguinal ligament. How? The arch fibers are like this. This one is the conjoint tendon. This one is the conjoint tendon, which is formed by both the fibers of this internal oblique and the transversus abdominis, like this. So, if this is the inguinal canal, just a minute, the pen I have put here, this is the inguinal canal and this is the posterior part. So, the conjoint tendon is forming the medial part of the posterior wall, and more medially there is presence of reflected part of the inguinal canal. Now, the last one, this is the anterior wall. The anterior wall from outside inward is formed by the skin, then the superficial fascia, then the aponeurosis of external oblique muscle. And behind that, on lateral side, you can see here the red fibers, which are the fibers of the internal oblique muscle, and these are the inguinal fibers of internal oblique muscle, that is forming the lateral 1/3 by the fleshy fibers of this internal oblique muscle. So, this is about the boundary, is the anterior wall, which is entirely formed by the skin, superficial fascia and the aponeurosis of external oblique, and the wall, anterior wall, is partially formed on its lateral 1/3 by fleshy fibers of internal oblique. Posterior wall is entirely formed by the fascia transversalis, and medial most part it is formed by the conjoint tendon and the reflected part of the inguinal ligament. Roof is formed by arch fibers of internal oblique and transversus abdominis, and the floor is formed by the grooved upper surface of the inguinal ligament, and medial most part there is lacunar ligament. Now come to the inlet and the outlet. If this be the inguinal canal and this is the inguinal canal, so this one from where something is entering, this is the inlet and this one is the outlet. The inlet is known as the deep inguinal ring, which is an oval shaped gap in the fascia transversalis and about 1.25 centimeter above the mid inguinal point. Now, the question is, what is mid inguinal point and what is midpoint of inguinal ligament? Suppose this is the anterior superior iliac spine. This one is the pubic tubercle. This is the symphysis pubis, and the inguinal ligament is present like this. Right. So, midpoint of inguinal ligament is the midpoint between this end and this end. This is this one. This is the midpoint of inguinal ligament. And what is mid inguinal point then? Mid inguinal point is the midpoint between anterior superior iliac spine and the symphysis pubis. That means this one. This is the mid inguinal point. And the position of the deep inguinal ring, this is 1.25 centimeter above the mid inguinal point. Right. So, this is the inlet of the inguinal canal. And what is the outlet? The outlet is formed by the superficial inguinal ring. Where it is present? Just a minute, this is the pubic tubercle. Now, the superficial inguinal ring is attaches symphysis pubis. Now, the superficial inguinal ring, it is nothing but a triangular gap in the aponeurosis of external oblique above and lateral to the pubic crest. Now, if this is the linea alba, the position of the superficial inguinal ring is like this. This is the position of the superficial inguinal ring. This is a triangular gap which is present in the aponeurosis of external oblique. This one is the triangular gap through which the inguinal canal is open outside, right? So, till now আমরা কি জানলাম? আমরা জানলাম what is inguinal canal, what are the contents of inguinal canal and the boundaries of inguinal canal. as well as the what is deep inguinal ring, what is superficial inguinal ring, and what is inguinal ligament. The last one, that is the defensive mechanism of inguinal canal, which is also known as shutter mechanism. এই যে একটা inguinal canal রয়েছে, সেই ক্যানালটা কি করছে? বেসিক্যালি this is through the inlet, it is connecting with the abdominal cavity, and through the outlet this is coming outside. তাহলে abdominal wall এর viscera বা fat বা any other tissue is supposed to come through this canal outside, but normally কি হয়? হয় না। কেন হয় না? Because there are some defensive mechanisms. What are those? Number 1, flap valve mechanism. কি জিনিস? The obliquity of the inguinal canal. Inguinal canalটা এইভাবে obliquely placed, তার ফলে কি হচ্ছে না, superficial inguinal ring and deep inguinal ring, they are not present in the same plane. তার জন্য কি হয়, during increased intra-abdominal pressure, the anterior and the posterior wall of this canal, they are coming close in contact with each other and acts as flap valve. মানে anterior posterior wall দুটো একটা আরেকটার সঙ্গে এরকম জোড়া লেগে যায়, so the canal gets obliterated temporarily. The next one, that is the demi-sphincter mechanism. The arch fibers of this inguinal canal, which is making the roof, is like this. During increased intra-abdominal pressure, এদের কি হয়, contraction হয়, this arch is coming downward to the floor. That's why this is going like this. That's why it will obliterate the canal. Next is the construction of the canal is such that opposite the deep inguinal ring, যেখান থেকে ক্যানালটা শুরু হলো, suppose this is the position of inguinal canal, this is the deep inguinal ring, and this is the superficial inguinal ring, right? So against the deep inguinal ring, which is the deficiency on the posterior wall of the canal, anterior wall is strengthened by the inguinal fibers of internal oblique, and superficial inguinal ring, which is the deficiency of the anterior wall of this canal, the posterior wall is strengthened by the conjoint tendon as well as the reflected part of the inguinal ligament. So this is making this canal more strengthened. Next one, this is ball valve action. What is that? In increased intra-abdominal pressure, the cremasteric muscle, they will contract, and in case of male obviously, and will pull the testis towards the superficial inguinal ring. Thus the outlet of the canal is closed just like a plug. This is known as ball valve action. Next one, this is slit valve mechanism. What is that? During contraction of the anterior abdominal wall, two crura of the superficial inguinal ring, these two are known as the two crura of the superficial inguinal ring, these are stretched laterally in such a manner that the opening is being closed. যদি এটাকে এরকম stretching হয়, obviously এই দুটো ক্রুরা কিন্তু they will oppose with each other, which will close this opening. This is slit valve mechanism. So these are the mechanism by which the inguinal canal, being a potential canal, is not the common, always it not is responsible for hernia, and the defensive mechanism is known as shutter mechanism. Again I repeat, what are those? Number 1, oblique direction of the inguinal canal, which acts as flap valve mechanism. Number 2, demi-sphincteric action. Number 3, ball valve action formed by the cremasteric plug. Next, slit valve mechanism, which is due to contraction of the anterior abdominal wall muscles, slit like closure of this opening, this is the superficial inguinal ring. And next one, this is the construction of the canal is in such a manner that opposite the deep ring, the anterior wall is strengthened by the fleshy fibers of internal oblique muscle, and opposite the superficial ring, the posterior wall is strengthened by the conjoint tendon and the reflected part of the inguinal ligament. So this is all about your inguinal ligament, and the most important of this inguinal ligament, inguinal canal, is inguinal hernia. In your next class, we learn about detail of this hernia. Thank you.